Now we're good.
Now we're good. So for those of you who've been watching me speak but no audio, we've been having technical difficulties. Brian, they could see me but not hear me?
Correct.
Right on, right on. How many of you reached out to DBH Events or Alicia to say, we can see her, but we cannot hear what in the world she is talking about. So thank you if you reached out to let us know that we had a tech support. The last 10 minutes have been wild. We had some issues. We had some tech issues. Brian and Dale from our communications team leapt into action to resolve many, many things. But we are good. We are good. You know that expression, I'm like a willow tree and I can bend. That's what we're doing. We are just a willow tree in the wind today. So we're going to roll with it. For those of you who have not met me previously, my name is Susan Holt and I have the honor and privilege of serving as your behavioral health director and public guardian in Fresno County. We do this live broadcast or recorded for those of you who are watching this not live, quarterly, and in between the quarterly director's updates that are on YouTube, we send out an email with just various updates that you all might be interested in. So without further ado, let's hop to it. Wanted to provide a little technology update. I'm finding it slightly comical that my first slide is about technology and we had technology glitches literally within the last 10 minutes. The world is kind of funny that way. I wanted to give everyone in the department a big shout out of appreciation for making do and managing through the countywide network service disruption. And when I say countywide, I mean the County of Fresno as an organization, not the County of Fresno proper as a geographic region. But within the county employee family, everyone's network, internet network was compromised. I wanted to give a shout out to our HITPM, Health Information Technology and Privacy Management Division. They leapt into action right away, worked hard across divisions to make sure folks had what they needed to switch out to a MiFi internet connection or utilizing embedded technology within laptops so that our work and our services to our community could continue. So big shout out to them. And I know Emerson Coleman from our team sent out an email explaining the cause, and I wanted to emphasize to everyone that it really was a internet service maintenance issue, not any sort of cyber attack. There had been some rumors circulating that perhaps there might have been some sort of nefarious or malicious activity, and that was not the case at all, thankfully. And the main information technology services department was able to get our internet restored literally at the end of the day. It was like right before 5 o'clock that things started coming back online. So no malicious activity, but it certainly was disruptive, and a big shout out and kudos to all of you for the spirit of continuity of service and keeping things moving. Speaking of cybersecurity, even though this incident was not that, I did want to give us all a reminder that our cybersecurity and scam prevention efforts need to be strong. It has been brought to my attention that some county departments have had scam calls and other phishing attempts land within their county departments, and the bad actors behind those scam attempts and phishing attempts are presenting themselves out as well-known, well-established governmental agencies or other pseudo-public agencies, as well as long-standing private businesses in the community. They make themselves sound very legitimate, and so the reminder here is to always be vigilant. Don't provide any information to entities you're not validating that you are intending to provide information. And pay attention to those county information security trainings. I believe I've mentioned this previously. Those are very brief and by intention. They know that you all are very busy, and so they're trying to provide us all short, digestible trainings and content so that information security is foremost in our minds all throughout the year. And then lastly, a technology update. So for our SmartCare users in the department, Our clinical care teams in particular, but this also affects, of course, our divisions who oversee contracted care, as well as our planning and quality management division, who has a heavy role in the rollout of closed loop referrals and many others. I wanted to share with all of you that our PQM team has a rollout plan in the works. Closed loop referrals are a requirement from the Department of Healthcare Services here in California. And the idea is just like it sounds. When someone has a referral to an important service, we want to close the loop. We want to make sure that the referral was received and that the person was connected, or we know the outcome of that referral. So that's what closed loop referrals are all about, and we have technology available to us through SmartCare that will provide an avenue for the closed loop referral system. I want to manage expectations right away by saying, it's not perfect. The system available to us is called Connex, if I recall correctly, and it's not our design. So it doesn't 100% line up with our current workflows, and so we may have to adjust a little bit of how we do our workflows to align with the technology available to us through the electronic health record. But our teams across divisions are working on that plan, and we'll start this slowly. We'll start with a couple of our access teams, test that out, make sure we understand how everything is working, and then we'll slowly roll that out across our system of care. That's on the horizon, coming up within the next, at minimum, couple of months. Maybe slightly sooner, but at minimum the next couple of months. Further out in the future, potentially for us, it's not a done deal, but potentially for us could be an artificial intelligence overlay in our electronic health record. So for many of our clinical team members, you may have heard of artificial intelligence assisted documentation. There are many different platforms for the use of artificial intelligence in clinical documentation. For example, I've accompanied my own parents to medical appointments, and their physician says, Mr. Holt, can I utilize this device to record our conversation? It helps me make sure that I have accurate notes of your visit today. And my dad says, I don't know what you're talking about, but sure, So technology is he's not a fan. But that is what we are hoping to be able to do in our clinical teams here within the department. Right now, it's available to counties through SmartCare, but we cannot implement it until we get through a little bit of county policy business that's outside of our department's span of control. As that all gets settled out and we have a policy that would help guide that, we'll bring more information to you. So why am I introducing the topic today when we can't access it today? Well, word gets out fast, and you all talk to other clinicians who have access in their work, maybe in other counties or in private sector. And I wanted to let you know that it's not our intention to avoid this technology. We simply have to have a county policy backing that launch of that program, and that county policy is pending. So more to come on that. Moving on from technology to a couple of facilities updates. So if you're new to the department, you might not be aware of this, but for those of you who've been with DBH for some time, we are intending to relocate our existing Crisis Stabilization Center, which is currently out at the old UMC campus at Kings Canyon and Cedar, and we're going to relocate that to our Heritage campus at Shields and Millbrook. Pardon me. We already relocated our psychiatric health facilities. The construction of the Crisis Stabilization Center has been significantly delayed. The PUF projects were also delayed. Unfortunately, construction projects are notorious for that. And we've had to make some adjustments into our plan. I'm really pleased with the team that designed the Crisis Stabilization Center new facility. They're really creative. Our capital projects team and facilities team came up with an option that allows us to continue our plan on a reasonable timeline to move the facility without further extending this construction project. And so We're calling that our contingency plan, because that's what they called it when it was presented to me, but now it's our actual plan. And so we've consolidated the footprint of the Crisis Stabilization Center into a smaller space than we had originally envisioned. So what does that mean? When we ultimately move, sometime probably this fall, we won't have as much capacity as had been our vision previously. It was going to be a massive crisis stabilization center. Our new plan, where we've consolidated that footprint, places us in enough capacity that's very comparable to the current number of persons that our crisis stabilization center can serve. So we maintain capacity, but we don't have that growth opportunity that we had envisioned. It doesn't mean it's off the table. We still have space available, but we might make a decision to keep the contingency plan as the permanent plan. So that's all to come. Why did we do a contingency? Because we really need to get off of the UMC campus. The infrastructure out at the building 319, where our crisis stabilization center is located, it's archaic. It is the reason we moved out of building 317 is the similar reason. The infrastructure could not support continued operations. Literally a few weeks ago, we had to have a team out at, I think it was 6 o'clock in the morning on a Saturday to address the electrical panel in the Crisis Stabilization Center, which needed urgent attention. And then when they were investigating that, they found a pipe that was spitting out water for the chiller, which had to also be repaired. And so we've really got to get off of that campus. Unfortunately, the construction delays have really caused us to be out on that campus far longer than we had intended. And so that's why we've executed the contingency plan. The other thing that helps me feel comfortable with the contingency plan, maintaining our capacity rather than expanding it right now, Community Hospital is engaging in a project that they intend in the time ahead, may take a few years, but they are building what's called an empath unit. That's an emergency psychiatric assessment and treatment and healing center. I think I got all the letters correct. But what you can think of that is, it's a crisis stabilization center connected to an emergency department, like a psychiatric ICU, if you will. And that actually is something where we would have to partner with them to create a claiming process for our Medi-Cal beneficiaries. But that will bring more capacity also into our community. So that made me feel comfortable about not expanding our future capacity in Heritage. More to follow. I anticipate sometime in September or October that we might move the facilities. Please don't quote me. All of that is subject to change. We have fire clearances yet to happen, as well as various and assorted final construction details. The last facilities update I have for you is any of our team members who are working at the Palm location. We have badge access that was implemented this week, which I know is a big relief to a lot of us who had to remember various and assorted codes, which had to change periodically for security purposes. I really want to express thanks and appreciation to all of the team members who work from the Palm location. That took a while to sort, again, technology, and working with our landlord and property manager on that project. But just this week, the team was registering badges. If you work at the Palm location and you did not yet have an opportunity to register your badge, rest assured our team is keeping track of everyone whose badge is registered. Concurrently, the code and the badges will work. I know that because before I registered my badge, I used the code and I got in just fine. But work with your supervisor if you have any concerns about your badge working properly. For members of our leadership team, their badges will also work because we have regular meetings in the Palm location. And for others who come on occasion for a meeting, we have a key fob system where a person might be issued a key fob to have access in and out of the secure areas, to utilize the restroom, for example. But we will make sure that folks who are coming out to that location have clear instructions on that. So that's my facilities update. I wanted to give you a little update on the Behavioral Health Services Act. So for those who are new, the Behavioral Health Services Act is part of the statewide behavioral health transformation. It's part of the state's efforts toward integrating mental health and substance use disorder care, ensuring that we have accountable care for all Medi-Cal members across the state, and it radically shifted how we can utilize millionaire tax, formerly known as Mental Health Services Act dollars, now known as Behavioral Health Services Act dollars. So we were required to create a 3-year plan, which we did. Big shout out to the teams involved in that. It was a heroic effort. I was really proud of the work of DBH. And that plan was approved by our Board of Supervisors, and it goes live. It went live. I should use proper tense. It is live now. It went live on July 1. So expect lots of change because we will have iterative adjustments and iterative implementation of new and emerging regulations. Previously, we've communicated out that some team members have had cost center changes, other team members have no change in cost center, so always stay in close communication with your supervisor about those types of things. We have new data tracking requirements, and we also have more data tracking requirements on the horizon. We'll work to make sure we have clear communication to all of you, and I have a communication slide coming up in just a moment. We have a new initiative, speaking of data. I think we've talked about it previously, but it's getting real because the state requirement to implement individual service level data tracking is on the horizon. If I'm not mistaken, we have to implement that by January. I could be wrong on that, but I think it's January. And so we have a work group internally that's been formed. Our Planning and Quality Management Division is the lead with other subject matter experts leading in certain content areas such as the technology side of the house, our plan administration team members, and our clinical divisions as well. We will make sure that everyone has detailed, clear instructions on how ISL will roll out. What is ISL? For those of you who have never heard of this before, you can think of it in this way. For each individual human being that we serve who has Medi-Cal and they receive a Medi-Cal claimable service, we send a claim to the state, and then the state can see that that service occurred. For that same human that we serve, let's say that they're in a full service partnership, and as part of the full service partnership, the person needed shoes, and we determined that that was an appropriate expenditure with the whatever it takes funds for that program. There's no current tracking of that as an expenditure tied to that human being. ISL would correct that. It wouldn't specifically say we bought shoes, but there would be a category to track a personal item that was necessary for the recovery and rehabilitation of that person, and it would be tied to the individually identifiable person. Similarly, when we do outreach, we may have a lot of expenditures, but all the state would see is that we did outreach to the community, but the state couldn't really see what was the impact. And so when we have individually identifiable human beings, we'll be able to have a code that ties that human being to that expenditure. So all of this is quite complicated, but our team is pretty good at simplifying things and providing good instructions. And so stay tuned for more information on what types of things have to have an ISL entry and what the rollout plan will be for that. What we don't have yet is the Behavioral Health Oversight and Accountability Transition Report. We pronounce that the BOTR because we pronounce all of our acronyms just about in behavioral health. We expect that to be released by the Department of Healthcare Services very soon, and that will inform further adjustments that we have to do in our data collection and our data tracking and reporting. Another new thing with the Behavioral Health Services Act integrated plan that is live right now is we've developed and are continuing to develop and refine a clinical outreach team that is specifically working with persons experiencing homelessness including persons who are living in encampments. And we're doing this work in close collaboration with the Office of Housing and Homelessness that is operated through the County Administrative Office. So our Housing and Related Services Division works very closely with the Office of Housing and Homelessness, and we are creating a new vision for outreach to persons experiencing homelessness in our community. And our clinical team is really an integral part of that community-wide approach. Our PQM team shared with me today that they are working on a BHSA program monitoring guide. It's not yet ready for distribution, but they are putting some finishing touches on that, and they'll be getting some input from some subject matter stakeholders internally to make sure that we have a meaningful tool available to all of our team members who are needing to monitor our adherence to all of the BHSA regulations. And so with all of that said, I want to just give a big shout out of appreciation yet again, but this one specifically for all of you who've been touched in any way, big or small, by BHSA. Some folks really aren't touched at all. I know some people's workflows haven't changed, that that there's minimal change to your work. So when you hear me droning on and on about BHSA, it might be a little boring if it doesn't immediately affect your day-to-day business. But for some of you, you have really big changes. Our PQM team in particular I'm thinking of, as well as our clinical teams who are in the midst of a redesign or have to do new data tracking. So we're in it together, and we'll stay in close communication. Speaking of which, we have a new communication tool. So I have a communications update for you. You may have seen recent announcements come through that you have a quality management action notice to review. And because we love to pronounce our acronyms, it's called the QMAN. Not to be confused with cumin, the seasoning or the ingredient you can utilize to make nice tasty salsa and other dishes. It's not cumin, it's QMAN. Not to be confused with human. But we love our acronyms in DBH. So the QMAN, Quality Management Action Notice, is replacing the news you can use. For some of you who've been in the department a long time, when we've had some new information that we wanted to push out, we've utilized what was the news you can use. And we were concerned that the language of a news you can use might sound like, if you're interested, check this out. We're in a different regulatory environment now where we, the Department of Behavioral Health, certainly have steeper consequences for failure to implement all of the new initiatives of the state, up to and including financial sanctions to the department. And so it's imperative that any new regulations or requirements are implemented system-wide throughout DBH and our entire network of service providers. And so our quality team wanted to make sure that it was clear that when we're pushing out information that it has an action associated with it. So from our quality management team, it's an action notice. So I wanted you to know the why behind this language shift. We did have a couple of glitches in the launch. Our team was really eager to make sure you all have information that's necessary to be able to make the changes in the care that we deliver. And so there was a couple of formatting issues with the first couple of those QMANs that were sent out. So if you saw them get posted and then through your inbox, then you saw they were taken down and then another notice of the same QMAN. It's because we had to make some very minor adjustments, revisions to those. I think the team's got a great groove now. I think we're on track. So be on the lookout for more QMAN action notices coming from the Planning and Quality Management Division regularly. Next up, a few words on the American Society of Addiction Medicine, also called ASAM, more pronouncing of acronyms. And I wanted to talk a little bit about the ASAM criteria, and specifically in the next couple of slides, the difference between ASAM criteria and regulations. So what is ASAM? ASAM is the American Society of Addiction Medicine, and it's a professional medical society that was established many years ago. Started out very, very small, I believe in the state of New York, if I'm not mistaken, in 1954. And it has evolved significantly over the years in scope and in the body of evidence for addiction medicine to stand alone as a specialty within medicine. And the name has changed many times as well throughout history. It's a physician-led organization that is inclusive of other professionals in the field of addiction medicine. If you're interested in learning more about ASAM, I have included a link, but it's super easy to remember. It's asam.org. You can look them up and you can learn more about the history. They have lots of tools and resources available, and I encourage you to check that out if you're interested. So now, what is ASAM Criteria? A lot of the time when you hear us say ASAM, what we actually mean is ASAM Criteria. So the ASAM Criteria is considered the gold standard as a guideline for treating people with addiction and co-occurring conditions. It provides a standardized, evidence-based, multidimensional approach to making sure we assess people across a variety of areas, and that it provides an established continuum of care with very clearly defined levels of care. It creates a standard for the professionals who are doing these assessments and providing the clinical care to make sure people are placed in the best level of care to match their needs, and that throughout that care, they're able to assess if they should stay in that level of care, go up a level or down a level, and then provide the protocols to transfer the person's care when necessary. So there's an intersect between the ASAM criteria and our Medi-Cal regulations. So the ASAM criteria provides that national standardization, as I mentioned, but it's not a legislative tool by any means. It's a professional standard. Not all states utilize the ASAM for their Medicaid programs. ASAM criteria prioritizes medical necessity rather than administrative rules or budget constraints. It's purely a clinical tool. Well, we all know we work in government, and we got plenty of rules, regulations, and budget constraints. So there's a little bit of a tension there between the clinical guides and the realities of operating in a Medi-Cal environment. So as I mentioned, not all states use ASAM criteria. A little more than 30 states do rely on ASAM criteria as a baseline for creating their regulations. But all states that implement retain some flexibility to shape how their Medicaid program for substance use disorder care is regulated. The state is the regulator for the state Medicaid program. For us in California, of course, it's Medi-Cal. So the Medicaid regulations dictate the state level funding, provider requirements, and covered services. So as I mentioned, not all states use ASAM. It's because it's not federally required. Now, if a state is under a waiver, which I'll talk about briefly in a moment, the waiver, the 1115 waiver, would require ASAM or another evidence-based level of care criteria. Many of the states who are under a waiver, like California, utilize the ASAM. So even when a state is using the ASAM criteria, the state Medicaid agency determines the reimbursement rates, any daily limits, prior authorization rules, and the rules associated with treatment facilities. So you can see that if not all states are utilizing ASAM, you would have some variation already. But then even within the states that use ASAM, because the state is the regulator, there's still state authority to make it a little bit different than what's actually in the ASAM criteria, so there's still some variation. California is one of the states. They rate their licensure rules and enrollment criteria differently from other states, and it again may look a little bit different than what's in print in the ASAM criteria. I mentioned about an 1115 waiver. So the federal government oversees the Medicaid program, and there are certain restrictions and requirements in Medicaid. But states have the ability at the state level, not the local level, but at the state level, to ask for a waiver of some of those rules and restrictions in order to demonstrate the value of doing services and funding it a different way. Our drug Medi-Cal organized delivery system exists in California for counties to opt into, which Fresno did many years ago. It exists through that 1115 waiver process. So the state was able to negotiate with the Centers for Medicaid and Medicare Services a package of benefits for Medi-Cal under this drug Medi-Cal organized delivery system, having ASAM as a platform or a foundation, but with other certain regulations. This allowed us to waive some of the rules. For example, we have what's called the Institution for Mental Disease IMD exclusion, where Medicaid will not pay for services in any facility greater than 16 beds. Well, that makes it hard to operate a facility. It's really expensive. So under drug Medi-Cal organized delivery system 1115 waiver, they said, okay, California, we're going to give you a waiver of that rule. You can claim to Medicaid in a facility bigger than 16 beds, but you have to do all these other things. And so that's where California is. We are in the midst of preparing for a big change. So why am I talking about all of this ASAM stuff today? Well, right now, all of our regulations are based on the ASAM Criteria 3rd edition. And already published, the American Society of Addiction Medicine has the ASAM Criteria 4th edition. So we are preparing to launch a system-wide learning process to educate all of our clinical care delivery system and others on the new criteria. So all of the clinical team members in our department, so all clinical classifications, sometime soon, not today, but sometime soon, will be enrolled in the ASAM 4 training. All of our leadership team will also receive that. So that's our division managers, our chief medical officer, our compliance officer. We will all, myself and the deputy directors will all receive that training as well. Some other team members who have a critical responsibility in our department in terms of quality management or plan administration or contracts oversight and other areas where knowing the ASAM criteria would be really important in executing their duties would also be assigned to the training. And then we also are offering to our contractor providers the ASAM 4 training. But, and like I said, California regulations may differ from what's in ASAM criteria. And the reason I'm explaining all of this today is I really want to emphasize that we're providing a learning process for ASAM 4 before the state has the regulations changed. So I want to make sure that's really, really clear that we're doing this to have a foundation of knowledge of what's in ASAM 4 so we can be ahead of the curve. We want to make sure that folks have it as a reference guide and have clear understanding of what's in ASAM 4, but it's not a regulatory authority. The regulations are going to trail. So always follow current regulations, even when we're learning something new that might be in the future implemented in policy, and be on the alert for potential regulatory changes ahead. And just about to the end, I know I'm a little bit long today. I wanted to give an update on peer support services. This is a long time coming. I'm really appreciative of the patience across all of our teams here in DBH that we've had long-standing vacancies in our peer professionals. Peer support professionals are critical in the care delivery system. I'm apologetic that it has taken us so long to get action, but it has been due to some changes in regulation and certification. It took a long time to negotiate with our main human resources department the peer support specialist classifications in light of those new regulations. But finally, in June, with great appreciation for all involved, our Board of Supervisors approved changes to our peer support classification. So now what that means is we will have an entry-level peer support specialist and a certified peer support specialist level in DBH. So I'm really, really excited to share this with all of you. We will be recruiting very soon to fill many vacancies in our peer support classifications. I'm super excited to welcome new peer professionals into the department, and you can be on the lookout for those recruitments coming sometime soon. And then I'm hopeful that we'll have also some training opportunities as well, so that our supervisors in the department and others have a deeper understanding of the classification and discipline of the peer support role. The peer support persons, if you're unfamiliar, have lived experience having a behavioral health condition themselves, being in a place in their recovery where they're able to utilize that lived experience in a professional capacity to come alongside another person with a behavioral health condition and help that person in their recovery journey as well. So it's a great role, and I'm really pleased to see some forward momentum for us. Lastly, today I'll close you out with a little getting to know Susan. For those of you who've been in these YouTube broadcasts in the past, I usually close with a little something that's happening in my life or personal reflections. And so I have a couple of things on the screen. I don't know if you can see them. There's some Band-Aids, and so there's a story behind that. I'll try to be quick. But there's a quote here that's from Peter Drucker, and the quote says, "Plans are only good intentions unless they immediately degenerate into hard work." And boy, doesn't that sometimes happen. Whew, sometimes we have the best of intentions and things just don't go to plan. And then we end up with a whole bigger project than we envisioned. And that happened to me recently outside of work. So I have the privilege that I get to visit my family, my parents, every week. I often take them dinner, and I help take care of my dad's feet. He gets a little pedicure from me, usually once a week. And a couple of months ago, he had a really bad infection in his skin, and he had to have home health care for it. And thankfully, he recovered from that, and he's doing well. But he was left with some scaly skin, and he was really overdue for a real good proper pedicure. So we did a proper pedicure. I took an afternoon off and went to visit with my folks and did a little more extended foot bath with Dad. And I did a little scrubby with a little gentle scrub and took off all the dead skin. In the midst of doing that, a teeny tiny little bit of skin was exposed and had a tiny little bleed. I'm talking like the size of the head of a pin. Tiny. But because he'd been through that infection, in my head, I was worried that he might be at risk for an infection because of that. And he said, "Well, put a Band-Aid on it." And I said, "Oh, sure, that's a good idea. Let me go get some Neosporin. I'll put a Band-Aid on it. We'll be good." And because I wanted to have an abundance of caution to make sure that no little germs could get in there, I doubled up the Band-Aid. I wanted to have a nice, good coverage on this teeny tiny little hole. And then I put too much darn Neosporin on the Band-Aid. And when I stuck it on his skin, it oozed all over the place and made a big old mess. And then it got even underneath the sticky part of the Band-Aid. And so I said, "Oh man, Dad, I made a big mess." He's like, "Oh, it's fine." And I said, "Well, no, let me just finish what I'm doing, and then I'll take the Band-Aid off and put a fresh one on. It'll be super clean. We're good." That was a noble intention plan that did not work out well and immediately degenerated into a lot of work. Because what I failed to appreciate, not being a medical person myself, was that when we did a little, pedicure leg scrub, he had baby skin exposed. And that baby skin tore off when I pulled the Band-Aid off, leaving 2 inches of raw skin on my sweet dad. And now my tiny little concern for a risk of infection became a big concern and risk for infection. And so then, I felt deeply pained and responsible for creating this big wound on him. And I had to think about how I was going to handle that because my plans degenerated. And so I'm sharing with you all today that when I make a mistake or when plans degenerate, my first thing is to take a deep breath And I often joke and say that a deep cleansing breath is very different than a heavy sigh. Truth be told, I had a heavy sigh to start with because I felt so bad. And my dad can't see that great, so he was like, it's probably fine. And I was like, no, Dad, it's not fine. Let me take care of this. So I did take a deep breath. And then you have to accept it. So that's kind of what I say to myself, accept it. And you gotta feel it. And a lot of times I'll say, shake it off, release it. This one was hard to shake off because I inflicted harm. I had the best of intentions and I ended up hurting him. And so that took a little longer for me to release because I had to forgive myself for the mistake and then let that go, because stewing in it was not doing me any good, and it certainly wasn't going to do my dad any good, because if he sees me worried, his blood pressure spikes. And so I had to accept it, I had to feel it, and then I had to release that. And then you have to adjust your plan and keep moving. And so my once a week visit has turned into multiple visits a week and a little bit of healing of my heart. And I'm super pleased to share the positive outcome of this story is that because we leapt into action right away and created a whole wound care routine. Again, I am not a nurse and I do not pretend to play one on TV. I have great respect for the nurses in our department. I would never presume to be a medical care provider on the physical health side. But I knew just enough of what to do, and his skin has healed beautifully. So we have course corrected. So that's a little bit about what's going on in my life. I try to keep this lesson relatable in terms of, how do we apply this type of a lesson learned in our workplace? Sometimes our plans don't work out. We may have a plan for the day or even a plan for a project, and it goes sideways. So sometimes that creates a lot more work for us, or we have to start over, and that's okay because we recognize it, we take a deep breath, accept it, feel it, release it, and then we have to adjust our plan and keep moving forward. And so I share that with all of you because that's what's happening in my life, and I hope you found that possibly interesting. Maybe not too disgusting, sorry about the open wound part of it, but a little bit of my life sharing with you. So we always take live questions. If you are interested in asking me a question, you can put it in the YouTube platform and Brian or Dale will read the question to me because one of my other tech support issues is I can't see your questions where I normally would be able to. Or if you're not on YouTube during the live broadcast, but you have a live broadcast question, you can email Alicia Corona at alcorona@fresnocountyca.gov. There is a little bit of a lag, so I'm going to stall while you formulate your questions, and I'll share another thing that did not go to plan. So my husband bought this water mug. I don't know what you call these things. I don't know if you can see it. He bought me this cup, an insulated mug for my water. And when I say he bought it for me, that's not really truthful. He bought it for himself and I liked it. And then he said, do you want it? And I said, well, I feel bad because I feel like I'm stealing. And he said, you can have it. And I was so happy to have it. And then within a number of days, I dropped it on the asphalt in the parking lot and I busted it. I don't know if you can see, like it completely busted the lid, but it still seals. So out of respect for my husband's pseudo gift, not quite a gift, but I'm still using it. So I've stalled properly. We have one question.
Okay, so it says, can you speak to information and transparency on the rumored Reorg 2.0?
Yes. Oh, what a wonderful question. So the person says, can I speak to the transparency about and information about the rumored Reorg 2.0? It's not a rumor. So we at the department executive level, but it might be a rumor to you because maybe I haven't shared that previously. So thank you so much to whomever wrote that question. I really appreciate it. The department reorganized 2 years ago, and we had at least a year of planning. It was a very big reorganization of the department's work, a really transformational reorganization of the department. And since that time, we've had some lessons learned. We think we might have some opportunities for some minor deviations in which managers oversee which functions. but it wouldn't be as massive of a reorganization that we've previously done. I don't have any decisions that have been rendered. This is something that we're still contemplating. We asked all of the division managers if they had input and ideas around that. Some of you might have been asked about your ideas and input. I'll ask you right now if you have ideas and input about an improved, more efficient and effective, any changes we could make in which functions of our department report to which divisions. I'm open to it. We don't have any structured plan. There's no launch date. There's no new divisions created. It's right now just at an ideas stage. But I'll be happy to report back on that in a future YouTube broadcast or an email for sure. So if you have ideas, send them on up. It's absolutely true that we are contemplating some minor reorganizations structurally. So that's a great question. I appreciate it very much. Anything else?
Just, thank you.
Oh, well, thank you for the thank you. That was very thoughtful. I'm going to check my messages from Alicia. Question from someone that reached out. Oh, same question. So can you speak to information and transparency in the rumored Reorg 2.0? So early stages of planning on that. We'll report back as we have some ideas shaped out, and you can hold me accountable for that for sure. All right, I think that's all of the questions. Nothing more coming through from Alicia, and I don't think anything over on the YouTube side. So I know I went long today. Oops, wait a minute, one more. Oh, Alicia says nothing else. Thank you, Alicia. So that's it. I know I went long today. I hope you all have a fantastic day, whether you're watching live or recorded, and I will catch you in 1 quarter live at the next YouTube broadcast or a recording if that's your preference, and then you'll get an email from me in the months in between. Have a great day.